this annual conference of the Standing Committee of European Governance, and you have asked me to close this meeting with some thoughts on the outlook for responsible health systems, with particular reference to the health workforce and patient care, and I am also pleased to comply. Before I start, however, let me say that I have the very highest respect for the profession, particularly at this moment in time when I'm not in such a healthy situation, and for the invaluable contribution you make to people's lives, to population health, and to society as a whole. And the theme of today's conference, Responsible Health Systems Policy, certainly strikes a chord with our European health agenda. Now, when I took office in November of 2012, I set myself three broad priorities. The first of these was to shift the widely held perception of health expenditure as a cost. I was in cabinet, as you said, for 16 years practically, and I always remember health being considered as a financial albatross around the government's necks, particularly the finance minister's neck. So I have to move from this idea of always looking at it as a cost towards the perception of health as an investment that contributes to inclusive economic growth. I always say health is a value in itself, but if of course it leads to better rates of presence in place of work, less absenteeism, more economic productivity and more economic growth, the better. Investment, which of course includes the education and training as well as professionals. And I believe we are making steady progress. This principle underpins the Commission's policy, which we publish as a document entitled Investing in Health, which establishes health in the EU's 2020 strategy for growth and employment. And our starting point in this endeavor, as I will say, is that health is a value in itself, and it is also a precondition for economic growth and social cohesion. My second target, and since when I was appointed, I knew that my term would come to an end after 2 years, I tried to choose targets which are more or less achievable during a 2-year period. Second, I am committed to fighting discrimination in all its forms. We've already organized at least 2 conferences, the last one the 8th of March, fairness in health. And everybody should have access, of course, to good quality healthcare irrespective of race, age, sexual orientation, status, etc. So one of my particular concerns is the need to overcome stigma and discrimination in healthcare. During the Greek presidency and the Lithuanian presidency, a lot of emphasis was put on mental health. And the third target was that of delivering key legislative proposals which I believe will have a major impact on people's life. First was the revision of the Tobacco Directive, which, as I always said, will ensure that tobacco products look like tobacco products and taste like tobacco products to make them less attractive to the young. And I know that you share my conviction that large picture warnings, as well as the prohibition of characterizing flavors, will lead to fewer young people taking up smoking. When I took up this office, I knew this would be a difficult fight. I didn't know it would be so difficult, however. And there were a lot of surprises. For instance, I was expecting the governments to oppose and the parliamentarians to approve swiftly. It happened the other way around. The governments approved rather swiftly, I must say, with some amendments, of course, and some compromises, bearing in mind that politics is the art of the possible, while the realistic opposition came from the parliamentarians. But finally the vote was 500 in favour and 60 against, which I think was a very good result. And let me take this opportunity to thank the Standing Committee of European Doctors for your strong support towards an outcome which I believe should pay long-term dividends. In the short term, our aim is to reduce the number of smokers by 2% over the next 5 years. And in addition, we have what is your favourite subject, now reached agreement on a new regulation on clinical trials. Now, I am aware that the CPME expressed certain reservations during the course of the negotiations. I consider, however, that compared to the recent proposal, we have reached a good outcome which addresses, if not all, some of your concerns. Patients have suffered and continue to suffer as a result of the decrease of clinical research in Europe, and it is patients who will benefit most from the new regulation. So even if a clinical trial takes place outside the European Union, if it's going to be applied and used within the European Union, then we have to ensure that the place, the country where the clinical trial took place under conditions and rules similar to those of the European Union. So I think we have protected patient safety and at the same time ensured that we get back to clinical trials being conducted in Europe. Because as you know, we had a 25% decline in clinical trials in Europe, which affects not only the pharmaceutical industry, but also the academic world. Don't forget about that. I think you're teaching about this, you don't need to be taught about it, that clinical trials are used a lot also by the academic settings. So the new regulation will ensure a high level of patient protection, while at the same time fostering clinical research in Europe. Allow me to turn now to matters relating to the future of the health workforce. For health systems cannot deliver high-quality care to all Europeans without a well-trained health workforce of sufficient capacity. And this is why the Commission's 2012 Action Plan for the EU health workforce puts the spotlight on the serious risks of staff shortages in the health sector and the need to avoid skills mismatches. Sometimes I wonder, when we have so much youth unemployment, particularly in certain countries, it's as high as 28% as regards youth unemployment, and then we need to import healthcare professionals from outside the European Union. When we know that in the future, even by 2020, we will need hundreds of thousands, if not millions, of new jobs in the health sector owing to vacancies. So it is true, professionals in health need to be equipped with the right skills and competences throughout their careers to stay up to date with technological advances and new clinical approaches. Of course, with the increasing mobility of health professionals, continuous professional development is even more important. Which is why recently we adopted a directive in the recognition of professional qualifications, which encourages member states to ensure such continuous professional development, so as to ensure safe and effective practices. I am therefore pleased to note that DG Sanco is working together with the CPME and the Consortium of Health Professional Organizations in this study on approaches to continuous professional development across Europe, a study which we support through our financial instrument, the so-called Health Programme. This study will help improve mutual understanding on professional development, and I look forward to your recommendations on ways to strengthen European cooperation in this area, which will further support patient safety throughout the European Union. I also warmly welcome the commitment and expert input of the CPME to the shaping of a European guide on education and training of health professionals in patient safety. As you will probably have heard today, our recent public consultation on patient safety confirmed that the majority of stakeholders see an added value for the EU to work on quality of care. And this is an important message, which I will pass on to EU health ministers together with the Commission's second report on patient safety to be published soon. We now need to reflect on how to continue action linked to the EU network on patient safety and quality of care when the joint action that co-funds it under the health programme comes to an end in spring next year. The network provides a useful mechanism for mutual learning of patient safety practices and quality improvement strategies. It represents, in my view, a successful collaboration between all EU member states and many stakeholders, that is to say patients, health professionals, healthcare managers and academia, that clearly demonstrates an interest in common work on patient safety and quality of care at EU level. Sometimes I ask myself the question, what will be the future of the Commission and health as regards competence. As you know, there's a very strong sense and dimension of subsidiarity. If you have a look at Article 168 of the treaties, it's evident that this is mainly the delivery and quality of services remains the responsibility of the member states. But I think health is becoming even more important in the political agenda amongst public opinion, even during the current political campaign for European elections. Health in some areas is becoming an issue. Candidates are being asked to sign patients' rights charters. So I think that in the future we shall probably have more legal competences to try and narrow the gap as regards health inequalities, for instance. We are not a European Union on health. We are an association of 28 sovereign states, but not a union of health, the same way as we are on state aid, on competition, etc. So I feel that there will be a political interest in giving more competences to the centre to harmonise more our health policies. I could be wrong, but my political antenna detects this interest, which goes against the trend in some countries of wanting less power to Brussels, although this power to Brussels is not, because after all, Brussels involves each piece of legislation which has been passed in the health sector and was approved both by Parliament and by the Member States. It was proposed by the Commission, but finally it's approved by the Member States. Ladies and gentlemen, the provision of good quality healthcare relies on a skilled and highly motivated health workforce. And while many of the issues that determine the working conditions of this workforce are shaped and determined at national level, your discussions this morning certainly highlight that the EU can indeed make a valuable contribution and provide a great deal of added value. I'll just give an example. I was, before I came here, attending the EU Chronic Diseases Summit, and I met some ministers who are concerned about the exodus of particularly doctors going to greener pastures. By greener pastures I mean, of course, where the salaries are better. And you can't stop that. The freedom of movement of workers, including healthcare professionals, within the European Union is one of the fundamental freedoms guaranteed in the European Union. But of course there is nothing to stop a member state to create incentives so that its healthcare professionals remain within either its own national territory or indeed its own provinces or regions within the national territory itself. So let me conclude by stressing the crucial importance of the involvement of medical and non-governmental organizations such as the CPME in shaping policy decisions and future direction. I deeply value your involvement and input and fully trust that our fruitful exchanges will continue in the future.
Well, thank you very much for this, Commissioner. Commissioner has agreed to answer some questions. If there are questions in the audience, please answer. Please introduce yourself so you know who you are.
I understand it has a GIF. Is it me or team? Okay. I'm board member of the European Patients Forum. Thank you very much for your clear statement, especially about the competence of European institutions regarding health. This morning we had very tough discussion. In the first session we presented some, I would say, really worrying examples from some member states about the situation with the labor of doctors, about the equity of access to qualified doctors of the patients living in those member states. Then we heard some data that obviously there are some member states with lots of difficulties, or some governments that simply don't want to understand that healthcare is something that is fundamental for their citizens, but not only, because the healthcare problems simply don't stay in some member states. They spread everywhere and they concern the overall union. And in the afternoon we were talking about the collaboration, in the second session we were talking about the collaboration and how we can actually bring into the political agenda that healthcare should be considered as priority and that European institutions should have more powers, especially in those member states where definitely they have difficulties. How can the patient movement and the doctors' societies support the political efforts towards more competences of European institutions, especially in terms of interventions for such member states? Because we also very well understand that the difficulties are there. We don't blame those governments. We think they should be supported and guided properly, but at the same time we believe we need stronger European voice in some countries. How we can support this process also politically?
Yes, thank you for this question, because these are topics which we are discussing all the time. And I always quote this example of how strong subsidiarity is by saying that EU health ministers only meet twice a year. The agriculture ministers meet every month, the foreign ministers meet every month. The health minister meets only twice a year in an executive capacity. Then I have two other meetings, informal meetings which are orientation debates. And when I said that we don't have a lot of legal competences, it's true for a legal point of view, but I'm not washing my hands of this problem, because otherwise your second question would be, then why do we have to punish them if we don't have legal competence? We have some legal competence and trying to use them all where they exist. But then there is something called political persuasion, political pressure. We act in our lives not only because we are afraid of something, of legal sanctions. There are other sanctions which are non-legal. One of them is political sanction or political opprobrium. So, in certain areas where it is clear that we don't have legal competences to force any government to do anything, let's take health inequalities, for example, by publishing tables, by publishing scoreboards on obesity or on life expectancy, no one likes being towards the end of a table. Everyone prefers to be at the top of the table. And this causes then oppositions, NGO, pressure groups to put pressure on governments. And it works. It works. So I see a lot of NGOs and individuals on matters where I do not have direct legal competence, but I can create a certain political atmosphere which could lead to action in the future. Whether this will lead ultimately to a change in the treaties as regards the particular article 168 which I mentioned, yes, it could. And if you want to reach that position without, of course, giving too much power to the sector, just to get the power in the center, I'm a firm believer, even in my political formation, in the principle of subsidiarity. But the principle of subsidiarity means that in those areas where it is better to do things together, we should do those things together. Let me give you an example. It was a very laborious process to persuade member states to act together on cross-border health threats. Imagine, how can you fight a flu, a pandemic, like the flu, with 28 different strategies or 28 different plans, which are not coordinated? And this has led now to further cooperation. I'm pleased to announce that in June, we shall sign for the first time the agreement on joint procurement of vaccines, which is a form of protection to patients, but also to governments as well. I remember the last pandemic, some of the small and medium-sized states in Europe had problems with supply, and also had problems with prices, because the joint procurement will mitigate against speculation in prices at the moments of crisis. And this is a voluntary agreement, so member states can join or cannot join. I'm pleased to tell you that almost everybody has decided to join, and by signing the joint procurement of vaccines, then they will be able to participate according to their wishes on any particular vaccine. And I hope that in the future it will be developed in something even larger to medicines and not just vaccines. So of course NGOs can do a lot in this regard by first creating this political atmosphere. But on those areas where EU action adds to value. Otherwise we would be justly criticized of just wanting more power, more competence for competence's sake. And perhaps another thing which one could do, and this is something I'm repeating everywhere, there is this tendency, both at national level and at European level, to treat health as something belonging only to the health minister, or health that belongs to the health commissioner, as if there are no financial implications, or that the finance minister should not also have a positive health policy, or that the urban planning minister does not take health into account. And the moment we reach that stage where health becomes an issue in different ministries rather than only in one ministry, I think we can register even more progress in the future.
Now, for some further questions, Dr. Didiers has indicated.
Thank you very much. João de Deus, I'm president of the European Association of Senior Hospital Physicians. Thank you very much for your presentation. I couldn't agree more with your priorities. I think, of course, health is an investment, like education. It's not an expense. Sometimes it's difficult to convince the governments of this, but we try to do it. And, of course, fighting discriminations and good access to all patients and legislation. So, I think I congratulate you for these priorities. This we share, of course. You also said about how essential is the training, how essential is the continuous professional development for patient safety and quality of care. And you also said about the shortage of doctors that we are all aware of. And my question is, because we see in some countries some attempts of test shifting, I mean, some tests that should be performed by doctors, should be a competence of doctors, getting performed by other health workers. For us, this is very dangerous and it puts in risk the patient safety and quality of care. This should not be a reason for test shifting. So my question is, what do you think about this? Because this is not a way to solve the shortage of doctors. Thank you very much.
The question from Norway.
Yes, my name is Hege Jessing and I'm the president of the Norwegian Medical Association. I would also like to thank you for a very interesting address on these important issues. My question is about patient safety, and I wonder if there is any European countries that have achieved important goals that maybe are even excelling and that can inspire us to, and so that we can learn from. Thank you.
Any more questions? So, Commissioner.
In these times of crisis, I am always recommending to health ministers to put an economic tag to their reforms. First of all, let's start from here. No system in the European Union is sustainable unless it is reformed. And today, even countries which have a sound financial basis, Germany, Austria, are receiving country-specific recommendations under the European semester. because even though they have no financial problems today, unless they reform the health systems with the demographic trend, they will face problems in the future. And today we have 11 member states who are receiving country-specific recommendations on health. But the crisis is also an opportunity. In the English language there is the expression, necessity is the mother of invention. Once you are forced, you are in a war or in a crisis, you tend to be more creative because you are forced to take certain decisions. So let's take Greece as an example. In spite of the huge problems which exist, bailouts and programs and conditions and IMF, etc., they have succeeded because of the crisis to introduce certain reforms, including the use of a prescription, which in actual fact is saving them millions of euros each year in the purchase of products. This applies to Portugal as well. And then we have to emphasize on this economic tag. For instance, when we were working on the Tobacco Directive, the Commission was criticized, sometimes even by health ministers, strangely enough, that you are going to create unemployment. Because if people smoke less, then you have to produce less cigarettes. And those countries whose economy is partly based on the production of cigarettes and tobacco products were arguing you will cause unemployment because jobs will be lost. My sardonic, sarcastic reply used to be, so what should the new health commissioner do? Promote smoking in order to increase the number of jobs? I said there's a solution. We can do both. We can save lives and at the same time create jobs. Why? Because even if we succeed in this modest objective of reducing the number of smokers by 2% over the next 5 years, which means in practical terms 2.4 million smokers less, that would mean billions of euros saved by the state in treating smoke-related diseases, and also the savings which an ex-smoker would make, I think he would use in other parts of the economy, which would create even more jobs than what the tobacco industry is looking at. And therefore, even when it comes to e-health, e-health is something good in itself because it helps patients. Rather than dragging people to clinics and hospitals, they can be treated at home and monitored at home. They have to be monitored, of course. The e-health doesn't monitor itself. They have to be monitored, but they can be monitored at home. But I have just returned from southern Denmark where they have a developed system of e-health, and in reply to the Norwegian question, also as regards patient safety. I think it is a form of guaranteeing patient safety, and that is replaced by what I saw in the region of southern Denmark, even the advanced projection of their new hospitals, the way they build the hospitals by consulting patients as well, getting them to see, to construct, literally construct the best hospital room, the ideal hospital room in the eyes of the patients. I think they have a very advanced system. One has to say, and this, by investing X euros, it will lead to X plus euro savings. I think this is extremely important right now. And the same applies to prevention. I have just returned from the Chronic Diseases Summit. This is the first Chronic Diseases Summit in the history of the EU. Why did I convene this summit? Because there is a tendency to treat ex post facto after the fact and taken after the fact approach to chronic diseases. This was colorfully illustrated when I attended the World Diabetes Congress in Melbourne, Australia, by a professor from Cameroon who said, when you have a tap which is leaking water, there are two solutions. You could put a bucket under the tap, or you could try and solve the cause of the leakage. And sometimes in health, even in treating chronic diseases, it's very convenient to dish out the most modern and the latest pharmaceutical products which do wonders, rather than going to the cause of the problem itself. And the statistics are worrying. If you look at diabetes, there is an